Welcome to all our participants. Today's topic is Cease and Desist, Arresting Seizures. The objectives of today's webinar are: number 1, define seizures; 2, review the pathophysiology of seizures; 3, describe the different types of seizures; 4, identify the causes of seizures; 5, discuss the emergency management of seizures and MOA of drugs. And finally, number 6, learn the long-term management of seizures, medical and surgical, and its safety. Today's speaker is Dr. Lynne Lourdes Lucena, who finished intermed at the University of the Philippines College of Medicine and did residency training in neurosurgery at the UPPGH. She is a professor of neuroanatomy at the People Christian College of Medicine. She is the chair of the Division of Neurosurgery, Department of Surgery at the Bicol Medical Center and at the Mother Seton Hospital. She is also the chair of the Philippine Specialty Board of Neurosurgery Incorporated. Dr. Lucena is a past president of the PCS Bicol chapter and past secretary of the PCS. Without further ado, may we now call on Dr. Lynne Lourdes Lucena.
This is my disclosure. And the objectives of the lecture, as was mentioned by Dr. Lai. And the outline, finally we will introduce seizures and epilepsy, definition, the epidemiology, the pathophysiology and etiology, the diagnosis of seizure and epilepsy with new seizure classification, the management of epilepsy, and the new anti-epileptic drugs. So what is seizure? It is actually an event. It is the transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. It could either be provoked or unprovoked. Provoked meaning you have identifiable transient factors which has lowered the seizure threshold of the normal brain. Or unprovoked, you don't have any of these identifiable reversible factors. And epilepsy is already a disease. It is defined as 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure plus 60% recurrence risk of another seizure, or the diagnosis of an epilepsy syndrome with each cluster of signs and symptoms customarily occurring together. Epileptic seizures occur in 1 to 2% of the population, with 6 to 7% of children in developed countries suffering at least 1 or more epileptic seizures. It is probably doubled in 7 to 15% in resource-poor countries like the Philippines. With 110 million population, it is calculated that around 77,000 people in the Philippines have seizures. The highest incidence occurs in the first year of life, then after 60, and also after 60 years of age. The mean incidence rate is 70 over 100,000, and the mean prevalence rate is 4.5 to 5 per 1,000. So what is the pathophysiology and etiology? It is actually more of an excess of the excitation stimuli, more than the inhibition. So with that, a clinical seizure occurs when the electrical charges of a large number of cells become abnormally linked together, creating a storm of electrical activity in the brain. You take a look at the slide of the division of the pie chart. You have 23% is more idiopathic and generalized, and 21.8% is more of the cryptogenic type. And the epilepsy classification right now, it has changed. From idiopathic, it is now called genetic, meaning it is the direct result of a genetic cause, or there has been gene and mechanisms identified. And what was used to be called symptomatic is now the structural or the metabolic type, meaning abnormalities has been traced from structural defects in the cortical or subcortical areas of the brain or metabolic deficiencies. Then the cryptogenic is now termed as unknown with no identifiable cause. Classification of seizures. You have the generalized and the focal type of seizures. Generalized, you have different types. You have the tonic, clonic, absence, myoclonic, clonic, tonic, and atonic. With the focal, it usually starts at one localization, like the temporal lobe or the frontal lobe, which can later on generalize or recruit other networks to have a secondary generalization. And usually, generalized have impairment of consciousness, while focal usually doesn't have impairment of consciousness. Okay? So both cerebral hemispheres are usually involved in generalized seizures, in which the seizure stimuli originates at one point and it rapidly recruits or engages bilaterally distributed networks. So these are the types of generalized seizures involving both cerebral hemispheres. You have the absence, which is characterized as like blanking out or staring into space. It used to be called also utimal. And the myoclonic jerks, and you have atonic, which is characterized by drop attacks or sudden loss of muscle tone. Focal seizures originate, as I said before, may originate in one area of the brain, but it can have secondary generalization. For example, you have a simple focal seizure without impairment of consciousness and can later on become complex focal seizures with impairment of consciousness. Or you can have a focal motor seizure with tonic-clonic movements of either the upper or the lower limbs, and yet later on having secondary generalization evolving with dreamy state, blank stares, or some of these patients may have auditory, olfactory, or even visual hallucinations. So as I said again, the focal seizures evolve to bilateral convulsive seizures, either simple or complex partial, involving both cerebral hemispheres. So it is then called secondary generalization. So what diagnostic procedures should be requested? You have your EEG, or if available, the video EEG, and neuroimaging, the cranial MRI, a PET scan, or a SPECT scan, or a simple CT scan, especially in patients with trauma, head injury, and strokes, especially hypertensive bleeds. And then you can request chemical laboratory tests, such as blood and urine tests, metabolic or toxicological screening, especially in patients with diabetes and other patients whom you are considering to have metabolic deficiencies, CSF analysis in patients with CNS infections, and molecular and genetic screening in those who you suspect have epilepsy syndromes. So when do you decide to initiate treatment? So the aim of anti-epileptic drug treatment is to achieve seizure freedom without adverse drug reactions. So your initial drug of choice should be the most likely efficacious one and the one most unlikely to cause adverse drug reactions. The correct anti-epileptic dose is the smallest one that achieves seizure control without the adverse drug reactions. And still, monotherapy is the mainstay of treatment in newly diagnosed epilepsy. Criteria for starting anti-epileptic drugs. You should know that the recurrence of seizures and its risk must be very sufficient. And recurrence risk after a second seizure in adults and children at 70%, with a second seizure occurring usually within 6 months. And seizures must be sufficiently troublesome, meaning you already know that this seizure would cause harm or potential harm to the patient. Take note of the type of seizure, the frequency, the severity, timing, and precipitation of these seizures. These are the different anti-epileptic drugs that had been present from 1860 with bromide before, and then to the year 2000, and then 2020, we have still newer drugs which are not actually available in the Philippines. And the next slide will show that these drugs in red are the ones which are marketed in the Philippines. So effectiveness is actually the balance between efficacy and safety and tolerability. Again, the goal of treatment is to achieve seizure control with minimal to no side effects to promote optimal quality of life. These are the old generation anti-epileptic drugs. You have phenobarbital, phenytoin, valproic acid, carbamazepine, and benzodiazepines. Take note of the adverse drug reactions or the possible side effects, and you have also the mode of action. And these are the newer generations of anti-epileptic drugs: carbamazepine, levetiracetam, lamotrigine, gabapentin, topiramate, lacosamide, sunisamide, and perampanel. This is the summary of the mechanism of actions of these anti-epileptic drugs. Take note that a lot of them are sodium channel blockers and also calcium channel blockers. So what do you do with those kinds of drugs? For example, you already have a patient with one anti-epileptic drug and yet the seizure is not yet controlled. You should not use two anti-epileptic drugs of the same mode of action. For example, if you have phenytoin, you have to use the same drug which has sodium channel gated action. So you should use another one that has a different mode of action, like levetiracetam. Why? Because if you use two anti-epileptic drugs of the same mode of action, you will just precipitate more adverse drug reactions rather than potentiate the efficacy of this drug. Okay, so epilepsy pearls. In summary, what did we learn? That seizure is actually an event, whereas epilepsy is already a disease. A clinical seizure occurs when there is an imbalance in the electrical discharges in the brain and when there is imbalance in the excitation and inhibition, meaning the balance tips more towards excitation. And there have been changes in the terminologies used in the classification of seizures. As we noted, idiopathic became genetic, symptomatic is now called structural or metabolic, the cryptogenic is now the unknown type. Main goal of treatment, you achieve seizure control with minimal to no side effects to promote the optimal quality of life. And effectiveness is a balance between efficacy and tolerability. And the ideal anti-epileptic drug, or comparable to the ideal anti-epileptic drug, should be the choice of pharmacologic treatment. It should be 100% bioavailable with fast time to steady state and linear kinetics, with no protein binding, no metabolism, and with no or little drug-to-drug interaction. Thank you for your kind attention.
Thank you for that insightful lecture, Dr. Lucena. We now have 54 logged in to go with webinar, and 3 through live streaming. We would like to thank our today's sponsor, GSK, and also our media partners, the Philippine Daily Inquirer and the Filipino Doctor. Before we proceed with the Q&A portion, let's have one of our panelists give her reaction. May I introduce our reactor, Dr. Benilda Sanchez-Gan. Dr. Benilda Sanchez-Gan is a cum laude graduate of biology at UP. She is a graduate of the UP College of Medicine. She did her residency in pediatrics at the UP PGH and did her fellowship in pediatric neurology clinical and another fellowship in neurophysiology, EEG, and epilepsy at the State University of New York Health Science Center at Brooklyn, New York, USA. She is currently a clinical associate professor and attending pediatric neurologist at the Departments of Pediatrics and Neuroscience at the UPPGH. She is the head of the section of child neurology, Department of Pediatrics and Neurosciences at the UPPGH, and she is also the head consultant epileptologist at the Epilepsy Monitoring Unit at the St. Luke's Medical Center, Kansas City. And we now call on Dr. Benilda Sanchez-Gan.
Thank you, Dr. Lai, for that kind introduction. Seizure is one of the most common neurologic disorders that we usually see both in pediatric and adult patients. Epileptic seizures, on the other hand, affect 1 to 2% of the population, with the incidence peaking in two periods, particularly during childhood and in old age. Dr. Lucena already discussed the definition, classification, pathophysiology, as well as the etiology and management of patients with epilepsy. I think one of the questions that we should be asking ourselves would be, why do we need to treat epilepsy? This is because studies have already shown, particularly those done in animals, that seizures can cause the following. It's capable of causing neuronal injury. Recurrent seizures can cause hippocampal injury. It can also cause brain growth retardation, alteration in learning and behavior, as well as in brain pathways. Now, whenever we see a patient with new onset epilepsy, we always tell ourselves, how are we going to treat this patient? So first and foremost, we need to be sure that this patient indeed has epilepsy. So we need to re-challenge the diagnosis. And then there would be some patients wherein the seizure attacks would be provoked by certain factors. So this has to be prevented. And then we always try to treat the underlying cause if it's possible. But the main treatment regimen that we usually use would be the use of anti-epileptic drugs. And then we also treat concomitant disease, if there is any, and we should always be attentive with psychosocial difficulties. And sometimes we need to consider other treatment options, the non-pharmacologic ones, just like the ketogenic diet and epilepsy surgery. Now, this was already mentioned a while ago, that in order to have seizure control, we could number one, use anti-epileptic drugs, but we can also use non-pharmacologic modalities. But the main purpose would be to improve the quality of life of the patient with epilepsy. Now, when to initiate anti-epileptic drug treatment, I think this was also mentioned a while ago, that we need to be sure that the patient unequivocally has epileptic seizures, and that the seizures need treatment with an anti-epileptic drug. This requires precise diagnosis of the seizure type, the epilepsy syndrome, frequency and severity of the attacks, the likelihood of relapse and remission, as well as precipitating factors. And there is a high risk of seizure injury. Now again, in choosing the right anti-epileptic drug, we need to balance efficacy with safety and tolerability, and that would make our treatment effective. Now, again, I would like to reiterate that the goal of treatment in epilepsies is to abolish seizures completely with minimal, if any, drug-related adverse reactions. Now, unfortunately, only around 60% of patients with previously untreated epilepsy will attain seizure freedom on a single anti-epileptic drug. Adding a second drug would have around 13% seizure freedom, but the rest of the patients would either need polypharmacology, or this would be patients who eventually develop drug-resistant epilepsy. For these patients with difficult to treat seizures, aside from polytherapy, we can also offer them the special diet for epilepsy patients called the ketogenic diet, or for other patients, then surgical evaluation can also be done. What is the ketogenic diet? This is a rigid, mathematically calculated, doctor-supervised diet. It is high in fat and low in carbohydrate and protein, with a ratio of 3:1 or 4:1, with 3 and 4 being the fat parts of the diet. It also involved calories and liquid restriction in the diet. So we have here graphs comparing the usual American diet compared with the ketogenic diet. And you can see how small the amount of carbohydrates that the patient should be taking. What would be the mechanisms of the ketogenic diet? This is still unknown, but there are 4 major areas of investigation. This would be the presence of cerebral acidosis, the presence of water balance, direct effects of the ketones, as well as alteration in brain energy substrates. I also mentioned about the epilepsy surgery. Surgery for epilepsy is a well-established treatment for adults with intractable seizures, particularly those arising from a single resectable epileptogenic zone. In children, aside from focal resections, hemispherectomy and other functional procedures like subpial resection and purpose colostomy can also be done. And the goal of surgery, of epilepsy surgery in children, is to reduce epilepsy-induced cognitive disabilities by stopping seizures as soon as possible. This non-pharmacologic treatment, the ketogenic diet, and epilepsy surgery are both available in the Philippines. So in summary, epileptic seizures can cause neuronal injury. There are factors to consider in choosing the most appropriate anti-epileptic drug for a patient, and that patients with drug-resistant intractable epilepsy may benefit from non-pharmacologic treatment like a ketogenic diet and epilepsy surgery. Thank you.
Thank you, Dr. Sanchez-Gan. We're now open for our Q&A. Our first question is from Dr. Haynes. Are there drugs, medications that can cause seizures?
Maybe we should clarify what type of drugs Dr. Haynes is talking about. Because if we talk about anti-epileptic drugs, then we know that some types of epilepsy, like those with myoclonic epilepsy, might have seizure aggravation with certain anti-epileptic drugs. So instead of controlling their seizures, what they would be having would be aggravation of the myoclonic seizures. And we see them when these patients receive, for example, the sodium channel blockers like carbamazepine, phenytoin, and even lamotrigine. But for some other drugs, like we know that lithium, what else? Antibiotics like meropenem, even penicillin, they are known to cause seizures even among patients without epilepsy.
For our second question, also from Dr. Haynes, does occipital extraaxial mass with surrounding edema and mass effect cause seizures? Maybe Dr. Lucena would like to answer.
Yeah. An occipital mass, if it involves cortical and subcortical areas, it can cause seizures, can generate seizures, especially sometimes since we know the occipital area, the visual cortex is there, you can have possible visual hallucinations or other manifestations of focal and then later on possible secondarily generalized seizures.
Third question still from Dr. Haynes. I guess Dr. Sanchez-Gan can answer this. What are examples of ketogenic diet?
Well, the diet is usually computed, and as I've mentioned earlier, this is a high-fat diet. So what would be an example? Sometimes we use butter and nuts as the major component of the patient's diet, but we usually ask a nutritionist to do the computations and the menu for the patient, so it would be well guided.
Another question. This message from Eric Asuncion. Yes, a 2-month-old, 2 months pregnant with anti-seizures. Okay, what can we give? I guess he's asking if the patient is already 2 months pregnant and has seizures, what medicine or what treatment can you offer this patient?
Yeah, maybe we should investigate first what's causing the seizure for this patient, because if it's secondary to something is provoking the seizures, like for example, the presence of hypertension, so controlling the underlying disorder or the disease would be better than starting with an anti-epileptic drug. And unfortunately, right now, in spite of the development of newer anti-epileptic drugs, there's still no drug that is proven to be safe for pregnant women.
May I add also, aside from investigating the cause, there should be complete diagnostics. For example, maybe at that time there's an undiscovered tumor or mass or an AV malformation in the patient. So all those things should be properly worked up. Starting an anti-epileptic drug may be hazardous because as of now, there's no completely safe drug for pregnant women, and completely diagnosing the cause of the seizure would be better than like a knee-jerk effect of just giving an anti-epileptic drug.
There's another question here. Being a primary care practitioner, how will you know if a patient is having a real seizure or just malingering?
Well, actually, it's a big problem, no? Even for an epileptologist like me, it's a humbling experience that sometimes you really will not be able to differentiate somebody who's, well, we don't actually call it malingering. It's not politically correct. Because some patients would be having what we call the psychogenic types of seizures. Sometimes it would be really very hard to distinguish one from the other. That's why we usually recommend simultaneous video EEG monitoring for these patients. But there would be also some clues, like for example, a patient having a generalized tonic-clonic seizures, the eye should be open during the attack. So if the patient is having a GTC seizures and the eyes are closed, then you think that this might be somebody who's not having a real epileptic seizures. So there would be some tips or some clues, but if the procedure is available, then the best way to investigate this would be doing a simultaneous video EEG monitoring.
Also, may I add, as Benny mentioned, psychogenic types of seizures, also in types like the absence, sometimes it is difficult to note whether the child is just daydreaming or is bored and not paying attention. So again, the diagnostic exam would be the one, like video EEG would be the one to confirm whether that patient really has seizures.
There's another question here. Can you expound more on the non-pharmacologic treatment of seizures?
Yes, when we call non-pharmacologic, then that would be the alternative treatment. So it means that you're not using anti-epileptic drugs for this patient. Except for the ketogenic diet and the epilepsy surgery, some other modalities, like for example, the use of acupuncture or the use of reflexology, they don't have a specific study, so we really cannot comment on whether this would be effective or not. But for when we talk of diet, then that would be more specific for ketogenic diet. Some would be using modified Atkins diet for older patients, and then of course epilepsy surgery. So non-pharmacologic would be not using anti-epileptic drugs.
Several questions again from Dr. Haynes. Drugs such as those for schizophrenia, like olanzapine, can cause seizures?
I really don't know, but I think some of the psychotic drugs for psychosis, some of them can cause seizures. Like for example, risperidone and one more. Of course, the older ones, haloperidol. So most probably the olanzapine also, it can cause seizures.
Okay. Regarding the mass that was mentioned a while ago, the definite treatment is removal of the mass through surgery.
Usually, yes. You should characterize also the mass, especially not just a mass, but it can be also an AB malformation. So all these things entail removal, but sometimes because of a possible scarring effect in the cortex, you may still have to use anti-epileptic drugs post-operatively.
From Jessa May Virtudazo, what is the treatment and management for febrile seizures? Is it common to occur consecutively 2 to 4 hours interval among kids aged 6 to 8 years old? But has no history of seizures. Not diagnosed with meningitis, just with colds and cough.
Yes, actually, the definition of febrile seizure is that you need to exclude the possibility of a central nervous system infection. The usual age of the child would be around 3 months to 6 years of age, but we've seen some patients having febrile seizures beyond the usual age of 5 to 6 years of age. And there is already a category, and we call it the generalized febrile seizure plus. And the plus there would be the presence of seizures with or without fever, or the presence of seizures beyond the usual age group of around 6 years of age. Now, febrile seizures per se can occur whenever a patient would be having fever, and usually it would be during the first to the second day of the illness. And yes, it can occur consecutively every 2 to 4 hours, or it can even occur for more than 1 hour. And that's what we call beyond the usual, we call it already more than 15 minutes prolonged febrile seizures, and then more than 30 minutes, that's already febrile status epilepticus.
Okay, the next question is from our classmate, Dr. Cecil Serrano. What is the time to do? When is it time to do surgery? When is surgery indicated? Dangers and prognosis. I guess this is for Dr. Lucena.
Yeah, usually epilepsy surgery when there is failure of pharmacologic treatment, especially if the patient's already on polypharmacy and patients have been suffering with adverse drug reactions, and there is no seeming control still of the epilepsy, then an epilepsy surgeon is consulted, and this is mapped out where the possible stimuli is coming from, and then that is the time when epilepsy surgery can be done. And the possible plus or minuses, or the advantages and disadvantages of epilepsy surgery could be discussed with the patient's relatives.
From Loretta Daiko, are there natural treatments for epilepsy like herbal?
Unfortunately, at present, we still don't have the formal randomized controlled trials involving the use of herbal medicines in patients with epilepsy. But of course, I think, is marijuana considered herbal? Well, cannabis, there are a lot of studies now on cannabis, and I think during last week American Epilepsy Society meeting, they already presented some studies on the benefits of cannabis in some patients with certain types of epilepsy.
Again from Dr. Haynes, is seizure and convulsion the same?
Well, actually, convulsion is more of a all convulsions are seizures, but not all seizures are convulsions, because convulsions would involve some motor component, whereas some patients with seizures, like for example what Dr. Lucena mentioned, those with absence, they have seizures but they don't have the motor manifestation, so they don't have the convulsions.
Ana Limpopo, for CKD patients or chronic kidney disease patients and chronic dialysis with seizure disorder, Are there renal adjustments or anti-seizure drugs?
Yes, there are. Particularly, like for example, patients on phenobarbital, you need to give an extra dose after the dialysis, also for lamotrigine. And for those with impaired renal clearance, there are also some guidelines on how to adjust the doses of some anti-epileptic drugs, like for example, levetiracetam.
From Biore Serrano, what can we give to a patient to stop the seizures if there is no IV access?
Yes, so actually for children, we use rectal. So in the emergency room, if we cannot find an IV access, either rectal or we can even do intraosseous, no? So we can use intraosseous. But now, like for example, midazolam, that can be given intranasal and buccal. You can use the buccal route also. And there are already studies on the efficacy of intramuscular diazepam, comparing it with intravenous diazepam.
From Melody Lasso, good afternoon also. With regards to the EEG, how often is the monitoring to arrive into conclusion whether a patient has or has no seizures? Can it be said that after 2 normal EEG, the patient can be declared seizure-free?
So actually, epilepsy is a clinical diagnosis. So I have patients with maybe 4 or 5 EEGs, normal EEGs, and they still be having seizures. So the EEG helps us when it is abnormal, but if it's normal, that doesn't rule out the presence of epilepsy. No, so we use the EEG in order to classify the type of epilepsy that the patient has. You can also use the EEG for those patients who are already seizure-free for more than 2 years and you already want to taper off the medication that the patient is taking. So if it's already normal, then more often than not, you can already taper off the medication. But we always say that for you to have an increase in the yield of abnormality in your EEG, you have to do it 3 times. If the first and the second would be abnormal, the possibility of getting an abnormality, the first and the second would be normal, the possibility of getting an abnormality would increase if you do 3 EEGs by around 90%.
Next question is again from Dr. Haynes. Does a child suffering from autistic spectrum disorder experience seizures?
They are actually comorbidities, but not all patients with autism would be having epilepsy. If I'm not mistaken, I think around 20% of them.
From our classmate again, Cecil Serrano. What kind of surgery do you do? What about minimally invasive procedures?
Yeah, I think there is a stereotactic type of surgery already that is being done for epilepsy surgery. It doesn't mean that you need to do outright hemispherectomy. So as Benny mentioned, there is the callosotomy and also hemispherectomy. But sometimes it depends, you ablate, meaning when you have epilepsy surgery, sometimes when you are able to plot the exact area where the stimuli is coming from, you need to ablate, or meaning you need to kill the area of stimulation. So that is what is involved in epilepsy surgery. And sometimes with hemispherectomy, they remove the areas which generate the abnormal stimuli.
Okay. Again from Dr. Haynes, is putting tongue depressor during a seizure attack is considered a correct?
No, we don't advise it anymore. Particularly for those patients who are already rigid with trismus, try to open the mouth and you would break the jaw. In some instances also, when you try to put something inside, like before we put spoon, diba? It's really hard, and then you break the tooth and then they aspirate it. So it's more dangerous than preventing a tongue bite. So we don't actually recommend it anymore.
You usually put the patient on the side so that the patient would not aspirate. But there used to be a notion that the patient can swallow the tongue, but of course that's not true. So you just put
You
it
just
and turn
bite
them
it,
to the
but you
side.
don't
Yeah,
swallow
you can bite
it,
it, but
yeah.
you will never swallow the tongue.
From Melody Lasso, should penicillin really be avoided in seizure patients with infection?
Well, actually, it's still some sort of an idiosyncratic reaction. So we don't know who would be developing seizures with penicillin. So if this is indicated in a patient, particularly, for example, in patients with rheumatic disease, we just know that penicillin can cause seizures, but we don't have the studies that for patients with epilepsy, this would actually cause an actual event.
From Christina Camara, this is our also a classmate.
I think,
Any practical guidelines when to start tapering seizure meds? How long should they be seizure-free before you start tapering, assuming EEGs are normal?
there is already a guideline which was published, if I'm not mistaken, in 2001, and it was already updated, I think, last year on when to withdraw anti-epileptic drugs among patients with epilepsy. Basically, the rule is still more than 2 years seizure-free with the normal EEG, and you know that the patient also that this type of epilepsy is not structurally related, which means that the MRI is also normal. Then you can give this patient a chance to be taken off the medication. But of course, there are some types of epilepsy, like for example, the idiopathic generalized epilepsies, or what we call the primary generalized epilepsies, like juvenile myoclonic epilepsy. They respond very well to the anti-epileptic drug of choice, but they would need treatment maybe around until around 30 to 40 years of age. And this would be the natural course of the epilepsy.
From Ronnie Baticos. What would be your recommendation for those employees that did not divulge their history of seizures?
Why?
I think we have to ask somebody from
The legal department.
HR.
Yes, I have actually experienced a patient who was on maintenance medications for his epilepsy. And what happened was he sought work with a call center. Okay, so he did not declare it. Okay, so during the time that he was on duty, he went into absence. So people were talking to him and he was like just staring. He was discovered. So meaning I told him when he came back to me, I said he was actually controlled for a long time. And then because of the work, the nature of the work that he went into seizures again. So I said it was hazardous for him to do that. So like work with call center agents, it's very important for them to be able to declare or not go into that kind of work.
I think this is also a follow-up question from the same patient, of the same person. Recommendations for their placement at work. This is the employee was a seizure.
Yeah, the employee was taken off he was fired.
But because he did not disclose.
Yeah,
right?
because he did not disclose. Because he did not disclose. So, but
I guess the question is what would be a recommendation for what type of work I guess can do?
Okay. So what kind of work? So you should not have types of work with sleep deprivation, like night security guard
Nurses.
or call center.
Yeah,
nurses or very active.
We also tell them not to apply as policemen, firemen, scuba divers.
Yeah.
From Catherine Hayes is securing the airways still the first aid measure?
Yes, yes. Still the ABCs of resuscitation.
Again from Dr. Serrano. What is life with seizure? Socially for parents with children with seizure, support groups, how about government programs, socially for the marginalized?
Yes, there should be life in spite of the presence of seizures. Right now in the Philippines, we have the Philippine League Against Epilepsy, and we have a support group. If you have patients with epilepsy, they can go through the web and look for the website, and everybody is invited to join the support group of PLAE.
This is the last question, again from our classmate, Christina Camera. If a patient has seizures from ruptured AV malformation, what is the golden time frame for surgical intervention?
Okay, for ruptured AV malformation, you should have already covered the patient with anti-epileptic drugs because further seizure may pose dangers like rebleed. So timing depends on the angiogram that was seen. Depends also on the possible location of the arteriovenous malformation because now we have different types of surgery or non-surgical, meaning you can embolize or you can take out the whole AV malformation, but it depends again on the diagnostics, what type, location, and size of the arteriovenous malformation we are dealing with.
So thank you for the engaging discussion, Dr. Lucena and Dr. Gan. To summarize, we discussed the definition and the different types of seizures, what's the difference between seizure and epilepsy. We also discussed the etiology, causes of seizures. And during the Q&A, we had a fairly lengthy discussion of the pharmacologic and also the non-pharmacologic treatment for seizure disorders. Okay. After this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials for this session. Thank you for joining us. We would also like to thank our sponsors, GSK, and the Philippine Daily Inquirer and the Filipino Doctor for their support as our media partners. We hope to see you again in a short while after this webinar at 1 p.m. for the next session on diabetes with Dr. Joy Fontanilla. Please invite your colleagues to join this continuing monthly CME webinar series. All webinar schedules and resources will be posted at Facebook, UPMed Webinars. You may also subscribe to our mailing list, UPMed-mailing list-2016. And you may also email us at upmedwebinars2016@gmail.com for any inquiries. On behalf of the UPCM Class 1991 and the UPMed Medical Alumni Society, we also thank our collaborator units, UP Manila Information Management, Mathematics Unit, DOST, ASTI, and Ms. Charisse Orhalo of UP Telehealth, our hosts. This is Joseph Lai, Dr. Lynne Lucena, Dr. Benilda, and Dr. Marisha Recto closing this session. We hope you have learned a lot from today's webinar. Please stay tuned for the next webinar which will follow immediately.